Top Bed Talk.
And thanks for inviting me to speak on behalf of the Irish Perioperative Medicine Society. My name is Aoife Lavelle and I'm a consultant anaesthetist in St James's Hospital in Dublin. Prior to that, I was locum consultant in Bart's Heart Centre in London, and I've done cardiothoracic fellowships in both Bart's and Harefield hospitals. So along with Aisling and Vicki, I'll be bringing you on a journey looking at enhanced recovery after cardiac surgery. And I apologise in advance for any overlap in the material. So, as you're all well aware, enhanced recovery after surgery programmes have been in place in many specialties for almost 2 decades. They use a research-based approach to select the most appropriate pre, intra and post-operative interventions to optimise patient outcomes and experience. Over 20 different guidelines have been produced in concert with the Enhanced Recovery After Surgery Society. And many of these guidelines are now well established in clinical practice, particularly, for example, in colorectal surgery. What's important to remember about these programmes is that they're multimodal, transdisciplinary, and they aim to promote recovery of patients undergoing surgery, reduce complications, and ultimately get them back to their normal activities earlier. So these programmes have been well received because they've led to reductions in length of stay of up to 50% compared with conventional perioperative patient management. Time to ambulation has been reduced, and we can actually show reductions in complications of up to 30 to 40% in certain surgery subtypes. And as well as this, there is evidence to show that there are increases in patient satisfaction, particularly relating to pain. But cardiac surgery is actually a little bit late to the game when it comes to enhanced recovery after cardiac surgery. So in 2017, a group of cardiac surgeons, anaesthetists and intensivists formed the Enhanced Recovery After Cardiac Surgery Society, which subsequently joined with the Enhanced Recovery After Surgery Society, and they became ERAS Cardiac. Since then, we've had the output of the first ever expert consensus recommendations for a cardiac surgical enhanced recovery protocol. And along with their recommendations, they've also provided levels of evidence for the recommendations, allowing individual hospitals to determine what is most useful and appropriate for use in their centre. So the guidelines were published in JAMA in 2019, and they were the output from a multidisciplinary systematic review of the available literature. The group identified potential enhanced recovery interventions, and then through a collaborative process, they reached an expert consensus on what to recommend for these patients. So these guys came up with a list of roughly 22 recommendations, which they rather sensibly divided into pre, intra and post-operative interventions. So I'm not going to talk too much or focus too much on alcohol and smoking cessation, as it just makes sense, but I will say that they recommend stopping 4 weeks preoperatively. In terms of HbA1c, they recommended measuring it, and they recognise that having lower HbA1c has been associated with significant decreases in deep sternal wound infections, ischemic events, and other complications. However, due to the existence of some evidence that pre-admission glycemic control is associated with a decreased long-term survival, they didn't recommend actually intervening, but they do recommend that it is used as part of risk stratification. In terms of nutritional deficit, it's interesting to see that 1 in 5 cardiac patients coming for cardiac surgery have a nutritional deficit. And even when patients don't have a nutritional deficit going in for cardiac surgery, all patients actually benefit from some nutritional support, given the huge stress of cardiac surgery itself and also the requirements of the body for post-operative wound healing. So they recommend giving intensive nutritional support, particularly protein, and results can be seen in as little as 5 to 7 days in the preoperative period. They also advise, obviously, avoidance of prolonged fasting. So I think that's a no-brainer at this point. we all know it potentially increases post-operative insulin resistance. And certainly in Bart's, when I worked there, we were giving our enhanced recovery after surgery patients clear preoperative carbohydrate drinks 2 hours before surgery. And this has previously been shown in non-cardiac surgery patients to reduce insulin resistance. It improves post-operative glucose control and it enhances the return of gut function earlier. Although the evidence is currently lacking in cardiac surgery patients, so it remains a weak recommendation. However, going forward, I would hope to see more evidence in that area. And Vicki told me earlier there will be an update to the guidelines in the new year. The next recommendation regards patient engagement, and it's the next item on the list of preoperative optimization strategies. So this involves education and counselling for patients. And the aim of this is to reduce perioperative fear, fatigue, discomfort, and also to enhance recovery and early discharge. And they recommend doing this through various mediums, so whether that's face-to-face, paper-based educational systems, or even online and e-health platforms that encourage patient engagement and monitor their interaction with the service. This brings me on to prehabilitation. That's become a huge focus in recent years as a result of our increasingly elderly population. With that ageing population, we're seeing more patients coming for cardiac surgery, and more of those patients have pre-existing frailty and multiple medical comorbidities. So frailty can be thought of as a lack of reserve to respond to stressors. It's something that we need to assess formally using a formal scale for it, rather than using our end of bedogram, even if it's something as simple as the Rockwood Clinical Frailty Scale. It's something that's simple, easy to be used, and people can be easily trained to do this. And frailty is important as it's associated with more post-operative complications, increased hospital length of stay, and a higher 30-day mortality. In terms of prehabilitation, the primary goal is to reduce the incidence and severity of post-op complications. So enhanced recovery, including prehabilitation, is in theory exactly what we need for these frail patients. We've already spoken briefly about nutritional optimization, but it also incorporates aerobic exercise, nutritional optimization, mental preparation, as we've sort of spoken about already, and anemia management. So in terms of aerobic exercise, this increases patient functional capacity, improves their health status, and it decreases sympathetic overreactivity. This improves insulin sensitivity and increases lean body mass to body fat ratio. And for cardiac surgery patients, this may improve physical and psychological readiness for surgery. This increased cardiorespiratory fitness is associated with decreased mortality, and this has led to its inclusion as enhanced recovery after cardiac surgery recommendation. As with all the other interventions, the pre-surgical ones anyway, it's limited by the urgency of surgery. So the optimal duration of prehabilitation has suggested to be 6 to 8 weeks. So depending on the urgency of surgery, this may or may not be possible. And certainly in my own cardiac centre, we rarely have a patient available for preoperative interventions more than 2 weeks ahead of time. And also clearly there's a trade-off between the patient's cardiac disease burden and their ability to train aerobically. However, there is evidence to say that it is safe for these patients to undergo it within reason. So patient expectation then and education need to be done as well, and that's in the setting of pain expectation, mobility, mood, and recovery time. The patients need to be aware of what they can expect to experience during the cardiac surgery admission. And then finally, I'm not going to focus on this too much, but if you have a lag time between when the patient has been brought to attention of the team, whether they're an inpatient who you need to wait for, their antiplatelet agents to wash out of the system, there are opportunities to intervene with anemia and iron supplementation, either oral or IV. And then I think in some centres in the US they use EPO, whereas I've never actually been in a centre that used it for those indications. So moving on to the intraoperative component of the enhanced recovery recommendations, we know that bleeding after cardiac surgery is common and that it's associated with worse outcomes. This study by Christensen et al. Looked retrospectively at over 1,000 patients and found that those having higher chest drain outputs had a higher 30-day mortality and post-op complications. So how can we reduce bleeding? Obviously, from a surgical perspective, you want your surgeon to check that there's adequate hemostasis, surgical hemostasis. But from our perspective, we can give antifibrinolytics such as tranexamic acid, and these are known to reduce surgical bleeding and have been proven beneficial in a large randomized trial in reducing the need for transfusion and reducing the need for reoperation rate. And this trial was published in the New England Journal of Medicine. They also found that patients who were receiving tranexamic acid had no change in the composite outcome of death, thrombotic complications such as MI, stroke, PE, renal failure, or bowel infarction. However, they did note that patients had a higher rate of seizure activity, which was also noted and confirmed in a large retrospective multivariate analysis of 11,500 patients. So that is the same across those studies. What they recommend then is reduce the dose of tranexamic acid in the elderly and in those with renal failure, and avoid doses greater than 4 to 6 grams and avoid greater than 80 milligrams per kilogram. I think they actually say 100 milligrams per kilogram, but some of the studies I've read and used kind of recommend keeping the dose less than 80 milligrams per kilogram. So back to the other recommendations. So avoidance of hyperthermia is very important. There's some moderate quality prospective studies that have shown that when rewarming on cardiopulmonary bypass, if hyperthermia occurs, it's associated with cognitive deficits, infection, renal dysfunction, and interestingly, if hyperthermia occurs at all in the first 24 hours post-bypass, patients have an associated cognitive decline up to 4 to 6 weeks afterwards. They therefore recommend avoiding hyperthermia and combining rewarming on bypass with continuous surface warming to aid overshooting. So avoid hyperthermia and then combine rewarming on bypass with continuous surface warming. The next intraoperative recommendation focuses on infection reduction bundles. So although the incidence of sternal wound infections has decreased to between about 1% and 4% of all cardiac surgery procedures, they continue to be associated with increased morbidity and mortality and decreased long-term life expectancy. So as a result, it's imperative we avoid them. So we have plenty of evidence to support the use of care bundles and infection of ICU, and these bundles have been adapted by the enhanced recovery after surgery for cardiac patients. So the general kind of overview that they have in the recommendations are that you eradicate nasal staph colonization, you give a weight-based dose of cephalosporin 30 to 60 minutes pre-knife to skin. Antibiotic redosing should occur if the surgery has gone on for longer than 4 hours, and prophylactic antibiotics should not continue for more than 48 hours. You also give guidance about skin preparation, chlorhexidine, and 48-hourly dressing changes. So then moving on to the final intraoperative section that they discuss, and that's optimization of sternal closure. So most surgeons, as you know, use wire cerclage for sternotomy closure, which achieves approximation and compression, but you continue to get side-by-side movement. So 2 multi-center randomized control trials by the same group compared sternotomy closure with wire cerclage versus rigid plate fixation, and they found fewer sternal complications and no additional cost when comparing wire cerclage to rigid sternal fixation. Patients also reported significantly less pain, better upper limb extremity function, and had improved quality of life scores with no difference in costs at 90 days. So while these studies were interesting, they were limited by size, but the Society added them into the recommendation. So They should be considered in all patients, but especially in patients who are at risk of sternal issues. So those with a high BMI, previous chest wall radiation, and patients with severe COPD. Now, having said that, despite having worked in 5 different cardiac centres, I have yet to see a rigid sternal fixation device used as described. So I don't know how well this recommendation has been taken up. And although, of course, the paper that led to the recommendations has only been published in the last 5 years, so it could just be a lag effect. But I wonder, is it more expensive in the UK or in Ireland, or is it just surgical preference to use what they're used to? So maybe Aisling can inform me about that. Moving on, post-operative hypothermia is failure to maintain normothermia 2 to 5 hours after an intensive care unit admission associated with cardiac surgery. Why do we care about this? So hypothermia, again, is associated with increased bleeding, infection, prolonged hospital stays, and death, both in cardiac and non-cardiac surgical patients. And there have been large observational studies that suggest if the period of hypothermia is shortened, outcomes can be improved. So again, we want to avoid persistent hypothermia, so we use our forced air warmers, raise the ambient room temperature, warm our irrigation fluids, and use warmed IV fluids. Then they also recommend after surgery that biomarkers for acute kidney injury are looked at, because acute kidney injury complicates 22 to 36% of cardiac surgery procedures. They recommend checking the biomarkers for early identification of at-risk patients and as a guide to an interventional strategy. Moving on to chest drain management. Most immediate post-cardiac surgery patients have some degree of ongoing bleeding. So it's obviously necessary to leave chest drain in situ when closing the chest, which allows the remaining blood a method of exiting the chest, otherwise tamponade or hemothorax would occur. Drains are, however, prone to clogging with clotted blood, and previous strategies to unblock drains, such as stripping or milking the chest drains, have been proven to be ineffective and potentially harmful. You can't break the circuit because that can lead to the introduction of infection, and actually stripping the circuit can lead to a very negative pressure in the chest, which can be dangerous if you have fragile grafts. So this led the team to recommend that tube patency should be maintained, but without stripping the tube, breaking the circuit. And they also recommended that chest drains can come out when the output becomes macroscopically serous. So delirium occurs in approximately 50% of patients after cardiac surgery. Again, it's reduced long-term survival, reduced freedom from hospital. It's associated with readmission, cognitive and functional recovery reductions. So early delirium detection is essential to determine what the underlying cause is. Is the patient in pain? Are they hypoxic? Do they have a low cardiac output? Is it sepsis? It's important to initiate appropriate treatment. So as a result, they recommend post-op delirium screening at least once per shift. However, they don't recommend any pharmacological adjuncts, as these have not been proven to improve delirium outcomes in cardiac surgery patients. So then, early extubation, as we know, prolonged mechanical ventilation after cardiac surgery, or any surgery for that matter, is associated with higher morbidity, higher mortality and higher costs. Prolonged intubation is associated with both ventilator-associated pneumonia and significant dysphagia. And as a result, they've recommended early extubation within 6 hours of arrival in ICU. And this can be achieved with time-directed protocols, low opioid dosing, and can even be done in appropriate high-risk patients. As we've mentioned, perioperative hyperglycemia has been associated with poor clinical outcomes. Interventions to improve glycemic control are known to improve outcomes. Insulin infusions are the most effective way to maintain glycemic control, but current recommendations are based on randomized data from non-cardiac studies. So future studies are needed in the cardiac surgical population to inform us. So then goal-directed fluid therapy has also been recommended, and this uses monitoring techniques to guide clinicians with the administration of fluids, vasopressors, inotropes, and to avoid hypotension and low cardiac output. And while most clinicians do this automatically, these are quantified goals, including blood pressure, cardiac index, systemic venous oxygen saturation, and urine output. And goal-directed fluid therapy trials consistently demonstrate reduced complications and length of stay in surgery overall, and specifically in cardiac surgery. Obviously, we need to use multimodal analgesia in these patients. We want to optimize post-operative pain control, as this accelerates normalization of quality of life and functionality. And if inadequately treated, acute pain can contribute to the development of chronic pain. So multimodal analgesia is an essential part of all ERAS pathways, and obviously we want to reduce our opioid requirements and the associated complications with that. So finally, some studies have shown up to 15 to 20% of cardiac patients develop VTE post-operatively. And as a result, they recommend both mechanical thromboprophylaxis throughout the hospital stay and chemical prophylaxis once adequate hemostasis has been achieved. Right, I'm running over time now, but I guess I just want to reiterate what enhanced recovery is after all that. So it's multimodal, multi-professional, evidence-based interventions at key points in the patient pathway that aim to lead to a reduction in avoidable complications and improve the patient's experience of care. It isn't something that you can try to set up in isolation, and while many of the interventions are relatively straightforward and what we do automatically and cost effective, it does require buy-in from all medical, nursing, allied professional teams and the patients themselves. And having helped set up the ERAS programme in Barts with Bonnie Kyle, which then got decimated by COVID, I know it takes blood, sweat and tears to get the programme up and running. So on that note, I'm going to hand over to Aisling, who's going to tell us about her experience in the Mater Hospital. Thank you.
So Vicki Morton is going to talk to us about enhanced recovery after cardiac surgery, but very much concentrating on anemia management. Vicki, thank you.
Hello, everybody. Thank you so much for inviting me to come and give this talk. I have nothing to disclose, a few objectives here. Just a little bit about myself. I'm a nurse practitioner, advanced practice provider in Charlotte, North Carolina, and I oversee our enhanced recovery program in 12 of our hospitals. In 18 of our, we have 18 pathways, so cardiac surgery, of course, being one of our big ones. I do want to focus on anemia optimization and iron deficiency, just because this is not an area that people tend to focus on a whole lot in a lot of surgeries, much less cardiac surgery, but we should. Because about a third of our patients will be anemic coming into cardiac surgery. Even more of them will also have iron deficiency. And we have a great number of patients that are non-anemic with iron deficiency. And it's pretty standard, to do a CBC prior to surgery, but if that hemoglobin is normal, or what one would consider normal in a hospital, they don't do any further studies. So screening for anemia as well as iron deficiency is very important. I just want to talk a little bit about, there's a lot of studies out there showing that anemia prior to cardiac surgery lends to poor outcomes. We know this. And it also, so patients have a higher incidence of renal failure, a higher incidence of stroke, a higher incidence of mortality when they're coming in anemic. Transfusing patients is also dangerous if it's absolutely not necessary. This study out of the University of Pittsburgh Medical Center, they looked at over 14,000 patients, cardiac surgery patients, and they follow them long-term, median follow-up about just over 4 years. About 6,000 patients did receive packed red cells within their perioperative journey. And they looked at short and long-term mortality as well as complications and readmissions. And so with all of these patients across the board found patients who were transfused had an increase in complications, a multitude of them, as well as an independent predictor of mortality and readmission. They also found the more units transfused, the higher risk patients were for all of these outcomes. In looking at patients going into surgery who are anemic and do get transfused, this looked at over 470,000 patients. About 33,000 of those were transfused at some point within 72 hours of surgery. And what they found was that the transfused patients had a much higher risk of mortality and morbidity than the non-transfused cohort patients. So high-risk patients didn't necessarily have a significant risk for blood transfusions, but the lower-risk patients that did get transfused had a very high excess risk of adverse outcomes. So we know that blood transfusions can save lives. It can be beneficial when it is appropriate, but when it is not, it only adds additional risk to these patients. In treating anemia and iron deficiency, we talk a lot about iron infusions. The recommendations, which we'll get to in just a minute, say if a person is screened for anemia and it's within 6 weeks of surgery, you should be treating them with iron infusion versus oral. Looking at iron infusion and erythropoietin or EPO, which was alluded to earlier, this study was looking at 25 total studies, over 4,000, almost 5,000 patients, looking at ESAs plus iron therapy, reducing red blood cell transfusion relative to just iron therapy alone, without any change in adverse events or mortality. And so there is this big black box warning with erythropoietin in cardiac patients that has been debunked through many, many studies. So it's proven to be safe and highly effective in these patients. This one looking at over 200 patients, and they really wanted to assess if anemia interventions were associated with reduced blood cell transfusion. There are some studies out there that indicate it's really not, but there are more out there that indicate that it is effective. And so basically, they found that the transfusion treatment group, they had less incidence of transfusions, of course, and they also had some less incidence of some post-operative adverse outcomes. So we know that EPO and iron for patients, it increases hematocrits, decreases transfusions, but there's no increase in adverse outcomes with EPO. But what about these patients that come in and you don't necessarily have a lot of time to optimize them? You're urgent patients coming in, and as alluded to earlier, they're having a Plavix washout, what have you. They're sitting in the hospital for a few days. This study looked at a very short-term treatment program, and this is actually what we use in our program. They looked at 1,000 patients, about 250 of them had anemia, and another 200 or so had isolated iron deficiency. They utilized EPO alpha, 40,000 units, vitamin B12, and folic acid with these patients. And they found that the treatment group had significantly reduced red blood cell transfusions, higher hemoglobin concentrations, and higher reticulocyte counts. The adverse events versus treatment versus non-treatment were not that much different. Another study looking at EPO and transfusions in cardiac surgery. This one was a randomized, single-blinded, using 80,000 IUs of EPO 2 days prior to cardiac surgery, about 600 patients. And really what they found was the treatment group, 17% versus 39% of the control group. So less transfusions, and post-op hemoglobin levels were much higher. So 40 to 80,000 units of EPO is proven to be safe. It's increasing hematocrit, decreasing transfusions. So what do you do with all this information? Because there's a ton of it out there, and trying to extrapolate and understand the safest route for your cardiac surgery patients can be difficult. There are some recent guidelines and consensus statements that are out there, and they all agree pretty much on the same basic approaches. And this sums it up pretty nicely, that you've got pre-op, intra-op, and post-op interventions that have to happen. And, they all say you need to screen these patients as soon as surgery is contemplated, and you need to have a treatment plan in place. For us, as soon as our patients are scheduled, they go straight to the lab, they get a CBC, and they get an anemia panel done so that we can capture those who are potentially not anemic yet iron deficient and treat them appropriately. We went over the guidelines, so there were some intra-op strategies. There are a lot of them. Bottom line is having some sort of intervention, some sort of strategies, having a multidisciplinary team involving everybody. It's not just a surgeon, anesthesiologist job. It's, perfusion, it's nursing, it's everybody, the lab, your infusion clinics. When we first started doing this with our infusion clinics, they had no clue what we were doing, and they thought we were crazy because nobody was optimizing anemia in our hospitals. But now it tends to be somewhat of the norm. So the question was in this session, is it really that different? And the answer is no, it's not. ERAS or non-ERAS, you should be doing this for all of your patients because it doesn't matter if it's cardiac surgery or if it's colorectal surgery. We see a large number of anemic patients coming into surgery, and a lot of times nothing is done about it, and we have an option to actually treat them and optimize them, as we should be doing. So what's the public service announcement here? What's the bottom line? Anemia is bad, we know that. Allogenic blood transfusions, potentially bad. Anemia and transfusions, really bad. That's what you need to remember. So thank you very much.
We're going to give you a round of applause, Aisling, for getting here. Well done. Thanks for trying so hard, and thanks for joining us here in Dingle virtually. You're going to tell us now about your experiences in the Martyr in Dublin about enhanced cardiac surgery, ERAS.
Yes. So good morning, and thank you very much. Apologies I wasn't able to be there in person. Unfortunately, I'm operating today. So I'm just going to give a brief talk about how we started ERAS after cardiac surgery in the Mater and just an update on our outcomes to date. So first I'll tell you that we started with our ERAS. We started to develop a working group between ICU, anesthesia, cardiothoracic surgery, but also involved perfusion, our ICU facilitators, theatre nursing, ICU clinical facilitators, and our NCHD. So the first step was trying to develop protocols and decide from a cardiac surgery point of view what patients would be suitable for ERAS. It was also important to try and delineate how we would identify these patients. We were going to identify the patients in our outpatient department, in pre-assessment clinic, and some would be flagged on admission to the hospital. That we decided that this should be part of the sign-in for the case in theatre and also for sign-out and also for on handover in the ICU so that everybody's aware that this is an ERAS candidate. There's a lot of cases, there's a lot of papers written by Zhu et al. And Wang et al. In terms of risk factors for failed extubation within 10 hours of admission to ICU. So we know that if, an older patient, if there's bleeding, use of a post-operative intra-aortic balloon pump, poor LV function, previous cardiac surgery, we know that these patients are not going to do well with ERAS and are not going to expedite in terms of extubation. So our inclusion criteria then, we looked at elective cases with a normal BMI, first cardiac surgery, reasonable lung function, good cardiac function on echo, and to start off with straightforward cases, so single CABG valve, myxoma, an ASD, planned surgery. So therefore, our exclusion criteria then was urgent or emergency cases, redo cases, poor LV function. We set an EF of less than kind of 40%. Anybody having CABG and valve, multiple valve surgeries, intervention on the ACA aorta was excluded at the start just to prevent any surges in blood pressure. Anybody with poor lung function, BMI over than 40, bleeding, I'll come back to, poor renal function, Euroscore 2 greater than 5, and frailty, although that's kind of a difficult marker. So that was the surgical inclusion and exclusion criteria. And then the next slide. So my anesthesia colleagues then worked on the pre-bypass considerations. So these patients all obviously had standard monitoring, arterial and venous access. They would have all had a baseline blood gas on room air with their ACT. Obviously, you can't be too prescriptive, but it was just suggested dosing for induction of anesthesia. There was guidelines given for midazolam, fentanyl, propofol, and rocuronium. Just to consider analgesia adjuncts, very important, obviously, to document their airway if it's difficult. Just suggest to maintain anesthesia with propofol or sevoflurane, standard antimicrobial prophylaxis, antitranexamic acids, and obviously good glycemic control as we would normally. So then post-bypass, obviously, as we discussed anemia, trying to maintain a hemoglobin greater than 10, make sure the ACT is at baseline, make sure the pacing is working, and document if they have an underlying rhythm. We want to make sure that they're on low-dose inotrope or vasopressor to maintain a MAP greater than 65. We want to optimize ventricular filling, that they have normothermic. We always do repeat blood gas and an ACT following chest closure. They should all be on low-dose propofol and fentanyl and make sure that they've adequate reversal of their neuromuscular blockade. And we also confirm that the patient is ERAS at sign-out with the anesthesia, and also that should be confirmed at handover to the ICU staff. The ICU group then worked on the ICU considerations. So on return from operating theatre, the ICU staff make sure that the patients are on the ERAS pathway. We establish if they have a true difficult airway. If so, we may consider daytime extubation, make sure we have difficult airway trolley available. If need be, we'll give them reversal of their neuromuscular blockade. They usually get some Sugamidex. And then we're the patient should be placed on SIMV or pressure support mode of ventilation. So the first hour after return from theatre is usually just to maintain stability. So their blood gas should show minimal acidosis. We're aiming for a base excess better than -6, so lactate less than 4. We want them on low dose vasopressor inotropic support. We had to put some limit on the bleeding. It's kind of hard to be fixed about that, but we're aiming for a drain output less than 1.5 mils per kilo per hour. So for an average 70 kilo patient, then you're looking at about 100 mils an hour. And we want hemoglobin greater than 9, and we do close and early ACT monitoring, and then they obviously get protamine as needed, particularly if they've had pump blood. Then we want to make sure that they maintain normothermia. Their propofol, we're aiming for less than 50 milligrams per kilogram, and fentanyl less than 1. Wean sedation as a priority over the opioid analgesia. They can get opioid boli as they needed for analgesia, and aim to have them on pressure support within 1 hour. We want SATs greater than 94 and FiO2 greater than less than 40%, and consider use of a fluid warmer and make sure they have regular analgesia. If they fail to meet the targets, it should be escalated, to one of the ICU or the cardiothoracic team. There's an option, obviously, to exit the ERAS pathway at any stage should there be any difficulty, any hemodynamic instability, which we've defined as a MAP greater than 60, CVP greater than 15, mixed venous less than 50, or rising vasopressor or inotrope requirements. Again, we had to set a limit in terms of bleeding, so greater than 100 mils an hour, we're certainly having a look at that, or if there's any problems from a ventilation perspective. So hour 2 after return from theatre, we want our pH greater than 7.3, base excess better than -4. Again, the bleeding should be reasonable. We want them on stable noradrenaline or adrenaline rates, and we want to try and wean off the adrenaline and stable gases. We're weaning the sedation at this stage, assess their neurological status and pain, and if the above parameters are met, then we're going to do a spontaneous breathing trial, and if they pass that, then we proceed to extubation. Not everybody is perfectly behaved when they come back from theatre. So if they haven't met the pathway for progressing to a spontaneous breathing trial, then we continue just to reassess them on an hourly basis. There is an option to exit the ERAS pathway at any stage, so any concerns about the patient. And the overall aim is to extubate the patient within 6 hours of ICU admission. And we have to make sure that their underlying heart rhythm is stable before they're discharged from ICU. So we developed our protocols from a surgical and anaesthesia and an ICU perspective. That was important to look at what our current practice was and what we were doing at the moment. So we did a post-operative audit of all patients admitted to ICU post-cardiac surgery, and then we did a subgroup analysis of people who would have met our inclusion for ERAS, and that was done between June and August 2020, and that was 93 patients in total. Essentially, just the demographics, the mean age is about 64, majority are male, and 60% of them are elective. The patients were admitted for a range of surgical procedure, but the vast majority are coming in for grafts, and then there's a mixture of grafts and valve surgery. So overall, what was important is that about 60% of our patients met with the MATTR ERAS protocol. The reasons for exclusion would have been elevated BMI, reduced surgery, complex surgery, EF less than 40%, and Euroscore greater than 5. So we were kind of reasonable with that. So this just looks at the physiological parameters on admission to ICU, and just confirmed that all patients were returning to ICU with relatively normal physiological parameters. And also we looked at sedation and fluid administration in ICU. So if you look at all comers just at the top, so fluid volume in ICU pre-extubation 3 litres, and for the ERAS candidates it's still 2.9 litres, so it's quite a lot of fluid, and there's kind of varying doses of propofol and fentanyl for patients post-op. We looked at our duration of mechanical ventilation in ICU. So for all comers, it was 14.5 hours. And for people who would have met the ERAS criteria, it was 12.75. So that's within your 6-hour target. So this just shows the interval between normalization of physiological parameters and the cessation of sedative infusions. So basically, there's just a significant time between normal parameters and discontinuing sedative infusion. And this was very much, we felt, like a cultural aspect. And again, we look at timing of extubation. So very small number of patients extubated between 6 o'clock and midnight, patients between midnight and 6 a.m., but by far the majority between 6 a.m. and 12. And cultural thing, people came back from theatre, were left asleep, they get a bath at 5 a.m. and then the propofol comes off at 6, and then you're trying to get a fluid bolus to get them awake and extubated to move them so the next day's cases can move in. So they're just interesting to see the timing of that. Overall, just looked at our complication rate, and that was low, and particularly the reintubation rate in the people who would have met ERAS, you can see, is relatively low. So that made us a little bit more confident that the cohort that we were choosing were going to be safe in terms of this new initiative. So what we learned from our audit was that on arrival to ICU, the physiological status of the patients is near normal. And despite this, our median duration of mechanical ventilation was 14.5 hours, and in the ERAS cohort, that was 12.75. Majority of patients were admitted on propofol and fentanyl. The time to cessation of sedation was 12 hours, and the median time to spontaneous ventilation was 10.25. And pH and temperature were not a delaying factor in that. So then in terms of introducing our ERAS protocol, we needed to focus on more rapid cessation of sedation and commencement of spontaneous ventilation to avoid any factors that may worsen pH, so things like hypercapnia, to maintain normothermia, to minimize sedation and admission to ICU, and then active measures to prevent or kind of manage delirium. Next slide. So we introduced the ERAS protocols. I will say there was a lot of work from the whole kind of ICU, anesthesia and surgical team in terms of education with all the nursing staff. We did an awful lot of bedside teaching in terms of the rationale for ERAS, what the evidence behind it was, what the protocols are, and why we were kind of introducing it in terms of for patient benefit. All the patients that were admitted that were flagged as ERAS, there was a protocol printed out for the bedside nurse. So particularly say with the ICU protocol on it, so they could know exactly hour by hour what they were aiming to do. This shows the time from critical care admission to cessation of sedative infusions. So pre-protocol for all comers, we were looking at like 12 hours, but post-ERAS protocol for all patients, that dropped to 6. For the ERAS group, it was 10.75 pre-protocol and 5 hours post. So we made a significant change in the time to reducing sedative in infusions. We also then looked at our mechanical ventilation again. So pre-protocol for all comers, it was 14.5 hours, and then protocol that dropped to 18.5. For the ERAS cohort, that would have been 12.75 pre-protocol, and post-protocol, the median value dropped to 7. So not quite exactly our target of 6, but the duration of mechanical ventilation has dropped for both groups. So a 45% reduction in ERAS patients and a 41% reduction in all patients. Overall, you can see that, pre and post protocol for ERAS patients, the median duration of sedation 10.75, then post ERAS that dropped to 5, and the median volume of fluid administered pre-extubation for the Lavelle patients pre-protocol was 2.9 litres, and then post was 1 litre. So that's a significant difference. Like a lot of the ERAS patients are nowhere near as fluid overloaded the next morning. You don't even need to put them on IV Lasix. You're often putting them on Frumil, like day 1 or day 2 post-op, because they're nowhere near as edematous. So it does make quite a big difference. Then again, we looked at the timing of extubation in the ERAS eligible patients. So there's definitely more of a significant shift of extubating people before midnight. There was some before we introduced the protocol, but that has definitely increased. And some patients will still be done between 6 a.m., but there is definitely a shift towards extubating people earlier as people get more comfortable with the protocol. So you can see the timing of extubation in all patients can be seen in the entire cohort of patients. I suppose it's not just the ERAS patients, the people who are non-ERAS as well are also seeing the benefit of reduced mechanical ventilation time. Next slide. And again, the physiological parameters in terms of lactate, pH and core temperature are all normal kind of pre and post, and that was never a limiting factor in terms of our ERAS. So our ICU, hospital and length of stay pre and post introduction of ERAS, so that hasn't changed hugely. ICU length of stay is a difficult marker to look at, I suppose, effectively. Sometimes our patients are medically fit for discharge and there's no space in the step-down high dependence unit, so that's why they end up staying. And I suppose the marker for us of introducing ERAS was not massively about really changing overall hospital length of stay. It was more about getting people up and out of bed earlier, getting them back on the feet, and increasing mobility and getting people back to normal activity. So we often will have people extubated earlier. They're sitting up and having tea and toast the next morning. They are up and out of bed. If they're out of bed, we have a new drain protocol. We're trying to get the drains out day 1, day 2. We take the pacing wires out day 3. So all of it means that people are that little bit fitter when they go home, a bit more mobile. The demographics essentially of the pre and post ERAS group. There was more obviously in the pre-ERAS group, but the age is the same. The gender mix is kind of same. And then in terms of comorbidities, it's very similar within the two groups. Just obviously, I suppose the demographics of patients in both audits are very similar. Majority of the ERAS patients had a cabbage. We've got a reduction now in the median duration of mechanical ventilation in all patients from 14.5 to 9 hours. And then in the ERAS group, that's dropped from 12.75 to 7. And we've got a reduction in our fluid resuscitation before extubation from a median of 3.1 litres to 1.1. Just to say that this has been several months of work to get this protocol in place and get this up and running. So this is, I think, a massive tribute to my colleagues in ICU. Thank you very much.
Aisling, thank you very much indeed under difficult circumstances. Thank you for sharing with us. We're going to have a very short panel. A few quick comments, ask you to ask this of each other. But actually, a comment that resonated with me is you said when they're sitting out of bed having tea and toast, that's what success looks like. And I think those of us who've worked in the cardiothoracic world or the major surgical world where patients come to a high care environment, that is what good looks like. And I think we now have data to suggest that drink, eat, move, living the dream is all part of the success. If it's okay, Aoife, I'll start with you. Do you think the failure to achieve that, to hit some of these targets, is pharmacology, physiology, or culture? And I've loaded the bases there to basically say I think it's all about the attitude.
I think it's the culture, having tried to bring in the protocols in Bart's. I was a fellow at the time and doing it with Bonnie Kyle, one of the consultants there, and I'd frequently come to the bedside, and when I dropped the patient to ICU, we do all the kind of analgesic management in theatre, we give them antiemetics, we optimise them so that we're delivering a patient who can be x-rayed, rolled, a set of obs done, and sedation turned off and woken up immediately. And I would still find that if I did not come back repeatedly to emphasise that this patient was suitable for extubation in the initial phases, there was a lot of resistance to it because it was unfamiliar. However, I was speaking to Vicki earlier, and over time, the nurses got more comfortable with the process and they got a real value out of it. And they saw that by making those little interventions half an hour earlier, 2 hours earlier, that their patients made huge leaps and bounds on the other side of extubation. So they felt like they were really adding value to the patient's journey, and they got really on board with it. And then COVID hit. It was...
Because there are some sort of totems of practice that have to be knocked down. For example, you can't extubate before midnight if you've been a bit late and that sort of thing. Vicki?
Absolutely. And I would probably, in the three that you mentioned, culture being the top one. I think that you can always overcome sedation, things like that, and write it in the protocol, but you can't always just change nurses or physicians' history and perspective on these things. So I think that takes much, much more work.
Aisling, in changing that culture aspect of it, any particular hints, top tips for us? Bribery, sticks, carrots, love, chocolate, flowers?
The nursing staff definitely appreciated having a protocol in place. I didn't realise we have 100 nurses in our ICU. So we did bedside teaching in groups of 5 and 6. I think that made a difference. And then we were present, for the first ERAS patients, just to encourage everybody and reassure them that they would be fine.
Aisling, we've been hearing around the world that in the post-COVID era, staffing's become very difficult. So there are a lot of whatever we choose to call them, temps or travellers or locums in place, which seems to have completely destabilised some programmes. Is that familiar to you where you are in Dublin, or have you still got a pretty solid core staff?
No, we definitely have a huge changeover of staff between burnout, people moving out of Dublin, lots of reasons. But now the new nursing staff are starting and they're just arriving in, and this is the status quo. This is how the Mater does cardiac surgery, and we do ERAS, so they don't know any different.
So we've incorporated education for all of our nurses when they start, whether they're hospital staff or they're traveler, and we put mechanisms in place for the education team to touch base personally with new staff, whether it's a nurse. I touch base typically with any of the nurse practitioners or physician's assistants that come in. But I've actually felt like having a protocol has helped, because otherwise it's willy-nilly and what surgeon does what, and now everything is a bit more streamlined, so it's helped.
I still have difficulty with which surgeon wants what, so I haven't gotten past that in my centre.
Now, that's a really interesting point, because, relatively recently reread Henrik Kellett's original Enhanced Recovery papers. As a surgeon, the first thing it says on the top of the first flow diagram is all pathways and protocols are about the procedure modified to the patient, never ever to the surgeon. And he wrote that as a surgeon, which is why he couldn't get it published in a surgical journal. How do you think we change that?
Audit.
Audit, there we go.
Yeah, early on, I think I've said this before, we collect the data for all of our surgeons, ERAS or not, but I typically will post outcome data for all surgeons, and they will see, the non-ERAS ones will see what the ERAS are doing, and you absolutely see the variation. And in their outcomes, and it kind of puts them on the spot.
We found actually in Bart's the surgeons who maybe were doing higher risk cases, because we did what Aisling did. We had inclusion and exclusion criteria to be on the ERAS pathway, but we found that the surgeons who maybe their patients weren't getting on the pathway were asking for them to be managed in the same way, even though they didn't actually reach our inclusion criteria. So I think once they see it being done well, seeing the results, they'll get on board.
Aisling, any final comments on that?
I was the surgical representative for the ERAS protocols, and I very much tried to band all my colleagues together and get everybody to agree on the protocol. And then I think feeding back with your outcome, and this is safe, we've had low risk of complications, I think that certainly helps buy-in.
If we can get a microphone here, and then as we get the microphone there, the final thing I'm going to ask you to comment on very briefly at the end is if ERAS should actually be for all, not just for selected patients, but please.
Ollie Pratt from Salford. I'm a non-cardiac anaesthetist, but I was fascinated by your anemia management protocol with EPO. So we in our trust do a lot of iron infusions, but we don't do much EPO infusions. And I just was thinking, should we be doing that for our non-cardiac patients as well? And what's the evidence base for that like?
There's a lot of evidence out there. Again, there's also some papers out there that show there is not much benefit, but there are more that show that there is a benefit. I personally think all patients should be treated the same way, cardiac, non-cardiac. There definitely, shows that EPO, even in short durations, can make an impact. And what we find is it really helps post-operatively. When you have these patients that are iron deficient, they tend to post-operatively require less transfusions. They can recover from that acute blood loss. I would take a look at it and definitely get your data and even start with a cohort, just and look at the before and after.
Last one from the floor. Thank you.
Thank you. It's good to be here again in Ireland. John Conslick, West Coast of Florida, I hope. Question in the beginning, you mentioned about physiology, pharmacology, and culture. When we started ERAS programs in 2016, it was culture because we had to combat that's not the way we do it here. Over the last 2 years of COVID, it has been physiology because most of our patients have not been able to go to the doctor. So when they come in, they are really not well taken care of from a multitude of different aspects, cardiology, sugar, whatever. Have you seen that as well over here?
Absolutely. I suppose I was in Harefield when COVID hit, and it just putting ERAS aside, I was shocked by how clinically frail, how further along in the disease process that patients were when they were actually getting to theatre. And it was actually quite overwhelming at the time because I felt I never got to do a heart that was going to do well, that would have been fit on the ERAS protocol and bounced out the door. And that went on for a very prolonged period of time. I felt like I didn't see a well cardiac patient for the guts of 4 months again. They were much, much sicker, and I'm sure when they look back, the outcomes will reflect that.
And Vicki, have you modified your prehab to account for the challenge with long COVID is some of the things that we think are good for people are bad for long COVID?
Mm-hmm. So we haven't really adjusted our prehab, and I really have been, the whole team has been pushing for some remote type monitoring and prehabilitation, just because some people still don't want to come in and they want to kind of stay secluded. So we need to be able to prehab them from afar.
So closing comments, Aisling, when this is all bedded in and all this wonderful work has got through the initial phases you've been discussing, will it be ERAS for all, or do you think there'll still be some selection process?
I certainly like the fact that the overall ventilation has reduced for everybody. I think it depends on your case mix of patients. We have a lot of redo congenitals, triple valves. They're not going to be extubated within 6 hours, but if you definitely have their mechanical ventilation and their fluid resuscitation volumes down, I think that's certainly going to help.
Yeah, so we do ERAS for all. If the surgeon is participating, which the majority are, it's ERAS for all. We collect the data, we break it down. If it's an elective case, an urgent, emergent, whatever. And, pulling all the demographics and comorbidities, we definitely have seen a shift with COVID, but it allows us to break it down and look at it in a different way.
ERAS for all until they fall off the pathway.
Brilliant, thank you. A round of applause for our wonderful
Top Med Talk.
Thanks for downloading Top Med Talk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn, and YouTube. And also, don't forget, Top Med Talk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.